I want to tell you a few things about Dr. Kelly and how long he's been here. Dr. Kelly has practiced in Macon for over 30 years. He is one of the founding partners with Forsyth Street Orthopedics. He is board certified in the American Board of Orthopedic Surgery. He has served in several different capacities. He is president of the Bibb County Medical Society. He has served as president of the Georgia Orthopedic Society, as chair of the Board of Counselors of the American Academy of Orthopedic Surgeons, an organization that represents over 30,000 orthopedics worldwide. He is selected to give a welcoming address. He was selected to give the welcoming address to new members of the 2006 AAOS annual meeting and was the 2006 recipient of the Georgia Orthopedic Society's Designated Service Award. He has been selected for membership in the American Orthopedic Association, an organization whose mission is to recognize leaders who will further the art and science of orthopedic surgery. He has served as a member of the Board of Directors of the American Academy of Orthopedic Surgeons. He is also a member of the Board of Trustees for Orthopedic Research and Education Foundation, where he serves as a member of the Executive Committee. Dr. Kelly is a member of the professional organization, including the American Academy of Orthopedic Surgeons, the Michael Hoke Society, the Willis C. Campbell Club, the Georgian Orthopedic Society, the Medical Association of Georgia, the Bibb County Medical Society, the American Association for Arthritic Hip and Knee Surgery. He also serves as the chair of the 20th Century Orthopedic Society. And yes, I did read that, but I'll bet y'all $1 he can't tell it all. Dr. Kelly was born here, was raised here in Macon, Lanier High School grad, went on to the University of North Carolina, went to the Medical College of Georgia in Augusta, did his internship at Baylor University, which just had their first Heisman Trophy winner, go Bears. Residency in general surgery at the University of Tennessee, and he did his residency in orthopedics at University of Tennessee Campbell Foundation. And since he was in his early teens, and he diagnosed his Cocker Spaniel with a bladder stone. He has wanted to be a doctor. And I will say, there's a catchphrase that we've all heard before, and it's for a money market company called E.F. Hutton. When E.F. Hutton speaks, everyone listens. Well, when it comes to orthopedics, locally, statewide, and nationally, when Dr. Kelly speaks, people listen. With that, I'd like to introduce Dr. Kelly.
Great introduction. I feel like I should probably leave now while I'm ahead. I will try to speak loud, have a fairly loud voice. If anyone in the back of the room cannot hear me, please raise your hand and let me know. Roger, thank you very much for the kind introduction, and thank you for the opportunity to be with this group this afternoon. We welcome everyone. We are delighted to have you here. I hope maybe you can learn a few things from me, and maybe I can learn a few things from you guys. So with that, I wanted to sort of introduce what we'll talk about today. I think everyone in the room is familiar with arthritis. We'll talk about what it is. We'll talk about also what we can do about it. Is there any way we can prevent arthritis, slow its progression, or is there any way we can treat arthritis? I've done these talks before, and I found that perhaps we all learn as much from some dumb speaker out there. Probably learn more from folks in the room. So I'm trying to leave room at the end for questions. I'll try to answer any questions that I might. If I don't know the answer, I'll get back with you. Well, you've already covered what I was going to say about my background. I actually grew up about 2 miles from Northside Hospital in Ingleside, High Point Drive, and went to grammar school right up the street on Ridge Avenue at Alexander Ford Grammar School. Then, as Roger mentioned, graduated from Lanier here in Macon. I did my training and came back to Macon in 1978. So this July will be 34 years. I've had the opportunity to practice orthopedic surgery here in my hometown. I've been married 40 years to Lawson, who I met in medical school while I was in Augusta. We've got 2 children, and we've got 2 grandchildren. A little little Lawson on the left and my grandson Jackson, who turned 7 today. We built our building at Forsyth Street back in 1989. My partner Chuck Richardson and I started the practice. Since then, we've grown to 7 orthopedic surgeons altogether. I will speak with you today professionally, but I'm also going to speak from a personal standpoint. As Bill Clinton would say, I can feel your pain. These are my x-rays up here. I had trouble with my knee, probably a sports injury related to trying to play basketball over there in high school. Injured my knee and had some trouble with it off and on. And then about 5 years ago, last month, finally had all I could stand and decided to have my knee replaced. So this is my x-ray. My right knee was replaced 5 years ago, and I'm glad to say it's one of the best moves I've ever made. It's been a delight not to hurt every step. The reason I had it done is I finally felt like an old man. I would go on a trip, I would get out of the car, and for about the first 10 steps, it was one of these things that probably everyone's familiar with. Now I'm glad to say I can get out of the car and not look like I'm 95 years old. But I can sympathize with many of you in the room today. Arthritis, the definition, basically arthritis means an inflammation of a joint. Thinking talk about what arthritis is, I thought it would be helpful to show a slide. This is the cartilage is the cushion on the ends of the bone that allows us to move the joint smoothly and without pain. And the synovial membrane, or the synovium, is the joint lining. It secretes a little bit of fluid that makes it easier for us to bend our knees without pain. If we develop arthritis, and again, arthritis is an inflammation of any joint. If we develop arthritis, the cartilage in our joints becomes more vulnerable to wear and tear. And you can see that this will lead to friction within the joint, and that leads to inflammation, and it's the inflammation that causes the typical symptoms of arthritis. Everyone in the room is probably familiar with these. Pain or swelling, which can be in multiple joints. Muscle weakness. Frequently the joint is tender to touch. The joint can be stiff, just like it was for me when I would get out of the car and try to walk. And a lot of times, particularly the knee, you can actually feel your knee grating. You can feel a grating sensation, or even feel noise or hear noise within your knee.
Yes.
There's some 46 million to 50 million adults in the United States alone who have some type of arthritis. And as baby boomers age, this number is going to increase dramatically. It's estimated by the year of 2030 there'll be some 67 million folks in the United States who have arthritis. So maybe there's hope for our business taking care of arthritic joints. So how is arthritis diagnosed? Basically, with the history, the doctor or physician asks you about the location, duration of your symptoms, we do a physical examination. There's a few simple tests we do, mainly x-rays, and we do blood tests to rule out other problems. Believe it or not, there are almost 200 types of arthritis that have been identified. Basically, most of us in the room, most of us in the United States, we live long enough, we get osteoarthritis, which is degenerative arthritis. That's where I'm going to focus most of my comments this afternoon. There are 2 other types of arthritis I'd like to at least mention. That is rheumatoid arthritis and gout. Rheumatoid arthritis is what's called crippling arthritis. It affects 1.3 million Americans, whereas probably 45 million have osteoarthritis. It's usually seen at an earlier age than osteoarthritis. Women are probably 2 or 3 times more prone to develop rheumatoid arthritis than are men. This is a type of arthritis that's really associated with significant deformities as the disease progresses. The typical symptoms, the swelling and pain, rheumatoid arthritis particularly have morning stiffness. That's a fairly characteristic hallmark of rheumatoid arthritis. And it affects the fingers, the wrists, the hands and feet. It can affect any joint, but particularly these joints. This can certainly lead to the types of joint destruction that we've all seen. At times, this can be really severe. Rheumatoid arthritis is a little bit different from osteoarthritis in that it's a systemic disease. It can affect any organ system, the lungs, the blood vessels, almost any system in the body. And we can have, with rheumatoid arthritis, can have fatigue, weakness, anemia, and even fever. The second type of arthritis I'd just like to briefly mention that we see a lot is related to gout. I'm sure people in the room have family members or friends who've had gout. This is a systemic disease. It's caused by buildup of a chemical called uric acid. Much more common in men than it is in women, typically in the feet and ankles. This is a kind of arthritis that people will say it hurt even to have the bed sheet. It can be excruciating when gouty attacks hit. This is the type of gout that Ben Franklin had. And it's probably related to maybe drinking too much wine or beer or maybe eating too much red meat. Although I'm not saying you don't need to do that, but sometimes if you have gout, maybe you shouldn't. As I mentioned, I like to confine most of my comments to what most of us in the room have, and that is osteoarthritis or degenerative arthritis. Basically, if we live long enough, we're going to get this. If we have enough birthdays, we'll probably get arthritis. It's present in most people over 60. It is caused by a breakdown of cartilage on the end of the bones, and there's a decreased ability of the cartilage to actually heal itself. I apologize for the screen jumping around. Maybe that's just me, but I think it's a screen. Frequently with osteoarthritis, there's almost always a family history. Either parents or grandparents have had this. Some folks get arthritis after a traumatic episode. We all know, I think it's common sense, that excessive weight puts a little bit more stress on the joints and can certainly aggravate arthritis. We can also see it in other conditions, whether it's diabetes or colitis or psoriasis. A number of conditions can cause arthritis. Typically, osteoarthritis affects the weight-bearing joints in the lower extremities, the hips, the knees, the ankles, but it can affect almost every joint in the body. We're familiar with the symptoms. Pain in the joints, usually worse by the end of the day with prolonged overuse, somewhat better with light exercise and with rest. And usually the stiffness in the joints can be relieved by just gentle motion. I wanted to show you what we do to help diagnose arthritis. The x-ray on your left is a normal knee. The arrow points to the space between the femur and the tibia. This is where the cartilage cushion is in our knee joints. In a normal knee, we have a nice cushion, nice space between the femur and the tibia. On the other hand, in an arthritic knee, as you see on the right, the cartilage starts to wear down. The space between the two bones gets less and less. And sooner or later, you have an x-ray like mine with just bone on bone. You can see how that would cause symptoms compared to what a normal knee would look like. Again, the joint space between the bones is narrowed compared to a normal space on the outside part of this knee. And another thing we see is a joint spur. This is a bone spur or calcium deposit, which actually is an attempt by the body to fight off the arthritic process, and it responds by actually building up calcium spurs. To diagnose osteoarthritis, I'm afraid there's no blood test we can do. But we do get blood tests to rule out other types of arthritis, like rheumatoid arthritis and gout that I mentioned earlier. I get asked every day, can arthritis be prevented? The answer to that, unfortunately, is probably not, but there are some simple steps that we can all take to lessen our joint pain, to improve function, and maybe slow the progression of the arthritic process. I want to take a few moments and try to discuss some of these with you in hopes that maybe it can help some in the room to relieve some of their joint pains. I think it's obvious that lifestyle changes can make an improvement. Weight loss, a healthy diet, regular exercise, all of these are common sense and can usually help with arthritis. The weight loss is important. The extra pounds obviously add stress on our joint. What they do, the extra pounds increase the risk of cartilage breakdown, particularly in our weight-bearing joints of the lower extremities. Even a little weight loss, 10 pounds, 15 pounds, sometimes can make a dramatic difference. It's been shown in the knee, for example, that every pound you lose, it takes 4 pounds of pressure off the knee joints. So if you lose 25 pounds, it's like losing 100 pounds as far as the knee joint is concerned. This is another question we get asked a lot. Does diet make a difference? Does diet affect arthritis? Well, the answer is that it's probably. Obviously, if we eat a healthy diet, we have less weight to carry around, and that will make a difference. Let me speak with you about something called omega-3 fatty acids, and probably some of you in the room are familiar with this. And the type of arthritis I discussed earlier, rheumatoid arthritis, it's been known for a number of years that omega-3 fatty acids can have a beneficial effect in controlling the symptoms of rheumatoid arthritis. Omega-3s are found in a number of foods, particularly fish like salmon, trout, mackerel, walnuts, olive oil, flax seeds, and squash. There are a number of foods that have omega-3 fatty acids. They have been shown to help in rheumatoid arthritis, and just in the last few months, in fact, just this past October, in a study from Bristol, England, it's been shown that omega-3 fatty acids can substantially, we think, relieve the signs and symptoms of osteoarthritis. This was a study I thought was very interesting. That's why I wanted to bring it up today. They fed omega-3 diets to guinea pigs. And the ones that had omega-3 had a 50% reduction in cartilage breakdown compared to the control group. The conclusion from this study, again, just done 3 months ago, is that all the evidence seems to support the use of omega-3 fatty acids in humans for osteoarthritis. It can probably help keep our joints healthy. For those that don't like salmon or mackerel or walnuts for some reason, it's the same thing in fish oil. Fish oil capsules contain omega-3 fatty acids. And the Arthritis Foundation recommends, if you take this, that you probably take up to 3 grams twice per day. Sounds like a lot of fish oil, but probably something worth trying. Not a whole lot of side effects from this. I think it's probably wise to check with your physician before you do so, but this new research is encouraging, particularly for those of us in the room who have osteoarthritis. We also get asked all the time about exercise. What should I do about exercise if I've got arthritis? Well, many avoid exercise. They're concerned that it will aggravate the pain in their joints. I got to tell you that low-impact activities, whether it be swimming, which is probably the best exercise we can do, walking, even bicycling, can improve mobility and increase the strength around your joints. Believe it or not, lightweight lifting exercises are very helpful. They increase the strength of the muscles around the joint and lessen the amount of pain, lessen the amount of stress on each joint. This is an exercise we do frequently for knee patients, particularly those who have had surgery. Strengthening the quadriceps muscle can have a dramatic effect on reducing pain in the knee. A lot of people forget that supportive devices can help out. A simple knee brace can help out with knee arthritis. It's amazing how much a cane or a walker can really make a difference for an osteoarthritic hip or knee. I preach this all the time. I've got to tell you, my female patients are very reluctant to use a cane. They tell me it's going to make them look old. I don't think it will, but they say that. But I probably, every 10 people I recommend it, I maybe get one to actually do a cane. But it really does make a lot of difference on your hip and knee. And of course, people with back pain get benefits sometimes from switching mattresses. I've got up here a firmer mattress, but I think the answer to a mattress for back pain is something that's comfortable. We used to recommend an extra firm mattress. I think now maybe we're getting away from that. Maybe a medium firm to firm mattress, whatever is comfortable. Whether it's a Posturepedic, Tempur-Pedic, Sealy, that doesn't make as much difference as what's right for you. So I think it can make a difference. If you got neck arthritis, certainly wearing a collar from time to time can make a difference as well. We're all familiar with drug therapy for arthritis. There are over-the-counter preparations, aspirin, Advil, Motrin, Aleve are common ones that are used a lot. And prescription medications. The NSAIDs are non-steroidal anti-inflammatory drugs. Whether it be naproxen or Celebrex, Voltaren, and Relafone, there's a basket full of arthritis medicines we use. But if you use these, they're great for the short term. Use them long term, though. At our age, you've got to be careful. There are certain side effects, not only the gastric irritation from taking the medicine, but if you take them long term, you need to have your blood checked. I tell my patients at least every 6 to 12 months to make sure you're not causing kidney problems or liver problems or even heart disease associated with some of these medicines. They're great medicines for relieving the pain, but it's like anything else in the world. It comes with some baggage, so you need to be very careful if you're taking these long term. Short term, 2 weeks, 3 weeks, 4 weeks, not near as much risk. Just make sure to take them with food so it doesn't upset your stomach. We get a lot of questions about chondroitin and glucosamine. This is glucosamine is a chemical that's normally found in our healthy diet. And some studies have shown that glucosamine, when combined with another chemical in our body called chondroitin, can be beneficial in knee arthritis and maybe even in other arthritis. I found in my own practice it seems to help particularly with arthritis in the hands. Some studies are inconclusive, some studies say it works, so it's still maybe a toss-up, but I've had enough patients tell me they've gotten benefit that I encourage patients to go ahead and try it. I think it can bring mild to moderate relief in some patients. I tell patients if you haven't seen any changes in 6 weeks, it's probably not worth continuing to spend your money. And proceed with caution. Some of these medicines can have effects, particularly if you're taking Coumadin or Plavix or blood thinner. You have to be careful. There's some evidence that it may even elevate your blood sugar. People with asthma can have problems taking this medication. Probably small problems, but something to be aware of. I think for the most part it's worth trying. Again, I think the main thing is if it hadn't helped in 6 weeks, I wouldn't continue to spend my money on it. Topical medications can help a lot for localized joints. You're all familiar with these. I have patients tell me every day how much Bengay smells so bad. Biofreeze seems to work pretty well. Icy Hot helps. These are some newer ones that we've had some luck with. They're prescription medications. Voltaren is a pill that you can take by mouth, but it also comes in a gel form. If you've got a localized problem, to use Voltaren is probably a worthwhile thing to try. Again, it's not a panacea, but sometimes it helps. You know, my treatment of arthritis, I think if you can do something that helps 10% here, maybe lose a little bit of weight, maybe you can take a drug that helps 15%, maybe some of this helps 10%, maybe using a cane helps a little bit. If you can treat it in increments, sooner or later you can get to where some folks with arthritis can get some pretty decent relief. So I don't think there's one panacea, but I think maybe thinking about doing a little bit of everything is sometimes a wise thing to do. Cortisone injections, we do a lot. It's something that can help, particularly with knee pain and other joints, shoulder joints. It's directly injected into the joint. We have to be careful. I don't like to give it routinely more often than every 3 months because it's been shown if you use it too often, now actually accelerate the arthritic process. So we try to be judicious with the use of it. On the other hand, I have a lot of patients, some of you in the room, that we give cortisone injections to almost every 3 or 4 months. So I think it's helpful. I know it helped my knee some before I had it replaced. This is a newer medicine. I say new, it's been out for the last 9 to 10 years now. Synvisc, Supartz, Uflexa. These are chemicals that are injected into the knee. They're like gel or lubricant that you put into the knee to help cushion the joint. A lot of patients come in and they say, will it regrow cartilage? The answer to that is no. It does not cure the arthritic knee. And in the best of circumstances, it will probably give us some improvement for 6 months, though I've had some patients who've gotten relief for 12 months or even longer. So I think it's worth trying. The nice thing now, the Synvisc one particularly, comes in one-shot injection. It used to be we had to give a series of injections, 3 or 4, once a week for 3 or 4 or 5 weeks. Now, some of the preparations we can give just one time. So that makes it a little bit easier on the patient. So we talked about all the different things that can be done short of doing surgery. And there are a lot of things that can be done. They don't cure the process. They can make it easier for us to deal with the process. The surgical treatments can be helpful as well. Some folks will benefit from arthroscopic surgery. This is the type of surgery that's done by putting a scope, which is about the size of a pencil, into the joint, usually through 2 or 3 small incisions. You can look around all throughout the joint. And if there's a problem there, sometimes you can correct it and make it better. We do this most typically on the knee and shoulder. It can be done on the other joints, elbow, ankle, even the wrist, even finger joints, if you can believe it. It's an outpatient procedure. As I mentioned, it's minimally invasive, usually just a couple of small incisions. For knee arthroscopy, the typical course afterwards is crutches or a walker for a week or two. The recovery is anywhere from a few weeks to a few months, depending upon the patient and depending upon the condition that we're treating. Let me just give you a couple of examples of what we can do arthroscopically. On the left-hand side of the slide is what's known as a torn meniscus, or torn cartilage. We see these sometimes in an arthritic knee, and all of a sudden becomes more painful. The patient's torn part of the cartilage in the knee, which is like the cushion between the bones. You can go in arthroscopically and actually take out the torn part of the cartilage, and in certain knees, this can make a big difference. More times than not, in an arthritic knee, the cartilage on the end of the bone will be worn down, be roughened. There will be some abnormal areas that look like sandpaper. Sometimes you can go in, you can smooth this over, and clean it out. But sometimes that can improve the joint. It doesn't cure it, but it can sometimes make it better. If this doesn't help, if you've tried everything else, then maybe you're a candidate for a joint replacement. You get asked this a lot too. When am I ready for a knee replacement or a shoulder replacement or a hip replacement? I tell patients, you can't tell that from an x-ray. I'm not smart enough to tell you when you're ready, but I can tell you this. When it gets to where the pain is really affecting your quality of life, the things you need to do or want to do, whether it's taking a vacation with your kids or getting out of the car to walk into McDonald's and it's giving you trouble, maybe it's time to think about it. If it's limiting your activity and things you enjoy doing, in my case, it got where I was really having a hard time playing golf, and I thought maybe I had a few golf holes left in my system, so that was one reason I decided to have surgery. Is it painful for you, particularly with the lower extremity problems, painful to walk more than a block or two? Does it interfere with your sleep? I think this is a big question, because if we're not sleeping well at night, it sort of ruins us for the rest of the day. Very importantly, have you exhausted? Have you done everything short of doing surgery? And most importantly, are you okay to have surgery? Are you okay from a medical standpoint? Any type of joint replacement is major surgery, and it takes a while to get over it. You need to be in as good a shape as possible to have this done. There are a fair number of folks we see who unfortunately tear the joint, but they're just too risky to have surgery. You need to ask yourself that question. You need to ask yourself, how long am I going to lay it up? When can I resume my activities? And probably most importantly of all, are you willing to assume the potential risk of joint replacement surgery? It's major surgery, risk that we all have to take, the same risk I took when I had my knee replaced 5 years ago. You worry about infection. There are things that are done to prevent that. Blood clots are a possibility. We give blood thinner now almost routinely for lower extremity surgery. The joint can get stiff. The joint over a period of time can wear out. There are hodgepodge of potential complications that are particular to each patient and to each joint. I thought long and hard about my own knee before I had it replaced, realizing as much as anybody in the room there are potential complications. They do happen. On the other hand, I would say 90 to 95% of the time, we can get a good to excellent result without these complications. But it would not be right to talk about joint replacement without talking about potential problems. Joint replacement can actually be done in almost any joint in the body, whether it's the ankle, the elbow, the wrist, the fingers, even the toe joints. But most of the joint replacements we do are for the shoulder, the knee, and the hip. We'll take a few moments to talk about these. Knee replacement, believe it or not, we're now doing 600,000 knee replacements per year in the United States, which I think that means we're getting older. We're getting older, and we've got a lot of miles on our knees, and we're wearing out. When that's done, the procedure is to replace the end of the femur bone, the thigh bone, with a metal component made out of stainless steel or titanium. And the upper end of the shin bone or tibia bone is replaced with a combination of metal and plastic. plastic has very low coefficient of friction. That's why it works so well with the metal rubbing against the plastic. There's very little friction, and therefore, theoretically, it should relieve the pain. This is what on the left, the knee looks like beforehand. In the middle, what the prosthesis looks like once it's been implanted. And then on the right, a typical x-ray after a knee replacement. In the hip, same thing can be done. An arthritic hip can be replaced by removing the arthritic hip ball and replacing that with a prosthesis that is, again, either metal, sometimes ceramic, and a socket that can be made out of plastic or metal. You probably read in recent literature in the New York Times and other places some problems that have happened with total hips, where the metal ball was placed with a type of metal socket. This looked like it worked great initially when it was done, and a lot of them still are, but there have been a certain number of problems with the metal or metal hip replacements. You'll probably see more and more about this as we go along. I think now more and more surgeons are getting back to doing the metal on plastic hip replacement, which is the one we've been doing since Sir John Charnley started doing hip replacements back in the late 1950s, if you can believe it. They're a little bit beside the point. When he started doing these, nobody else had done this. He decided to do it, didn't know what material to use, didn't know about polyethylene, which is the plastic we use. So he used Teflon, just like you have on the frying pan. He used Teflon component for the hip socket. He put in about 200 of these, and they worked great for about 12 months. And every one of them started showing signs of infection and drainage. And Sir John Charnley, he was eventually knighted for his work in total hip replacement. Sir John Charnley had to go back in with every one of these patients. I can't imagine this. Talk to them about the problem and take it out and do something else for them. So he was a real pioneer, brave man. He finally came up with the total hip that we do today in the early 1960s. And the trick was to find out how to keep the femoral component in place. The femoral component slips into the femur. And the problem was they didn't know how to put it in place. So he experimented around and finally went to the dentist, who had been using a material called methyl methacrylate, which is bone cement, since the early 1950s. And he said, maybe that'll work with a hip replacement. And we still use it. Almost 50 years later, we're still using what he came up with, what he stole, thankfully, from the dentist. Shoulder replacements, shoulder prosthesis, again, is a metal component with a plastic socket. Picture on the right is what it looks like afterwards. Picture on the left, I'm sad to say, I hurt my shoulder. I hurt my shoulder 20 years ago snow skiing. I think you can see that the right shoulder doesn't have great motion because I don't have any cartilage left. So sooner or later I'm going to get up the guts to go for my second joint replacement. But just to say the shoulder replacement is a very successful operation, becoming more and more successful as we learn. I just want to say a word about another question we get in the office a lot, and that is, can you do a partial replacement? About 20% of patients have a knee that is involved in only one side of the joint, such as the x-ray you see up here. The other side of the joint still has, as you can see, a nice joint space, still has nice cartilage. Well, these patients, these 20% or so, can actually benefit what's called a partial knee replacement. And that is, you replace, as you might have guessed, just partial of the knee joint, just half of the knee joint, again with a metal and plastic component. This is what the prosthesis looks like in the joint. Again, you can use a shoulder incision for this procedure. The x-ray on the right shows what a half a knee replacement looks like. Usually a shorter hospital stay, maybe just a day or two. Usually a quick recovery, usually a more rapid return to activities. Just in the last couple of years, actually, they've taken the partial knee replacement and maybe moved it up to the next level. This is something called a Makoplasty, which is a robotic knee that we again get a lot of questions about. This is a partial knee replacement. You cannot do a complete knee replacement with a robot, but you can do a partial knee replacement with what's called robotic surgery. what you do with this, you actually take a template or a CAT scan of the knee ahead of time. You can determine on the CAT scan exactly what part of the bone in the knee needs to be removed. Then you can actually download the CAT scan into a computer, and the slide on the right shows what the image looks like in the operating room. Basically, you take, this is a burr that's hooked up to the computer. You take this burr, it's hooked up to the computer and the robot, you put that into the joint. You just take what is green on the computer and work this burr around just like a little burr and make it white. By doing that, you remove the arthritic bone. The robot doesn't do the same. The robot's connected to your hand, but what the robot does, it keeps you from taking off unnecessary bone. This is something that's been available for knees now for a few years. It's becoming more popular, and now, just in the last year, it's been expanded to the hip joint. The jury's out on the hip joint, but the jury is becoming more and more, the answer is becoming more and more obvious about Makoplasty for the knee joint. And this is what a Makoplasty looks like. Again, it's a partial, not a total knee replacement. Before I finish, just a word about the future. Arthritis is an interesting disease because it seems like every week there's a new discovery. Going forward, I think the answer to a lot of our problems, if we live long enough, is going to be stem cells. I think these stem cells are human cells that can be taken from the body and they can actually be changed to special types of cells. Research has shown that they can actually repair damaged cartilage. So, this has already being done in certain places, particularly in Germany and other places in Europe. These stem cells are harvested through an incision over your hip crest. They're taken to the lab and actually grown for a few weeks. And after a certain period of time, after they become specialized cells, they can be injected back into the knee joint, into the arthritic knee. They can actually repair some of the damaged cartilage. This has been something that has been in the lab for a number of years, still in the research phase for the most part, but being done clinically now. Folks who had these done, some of the patients who have had trouble for a while, who were considering knee replacement, have had this done and just feel like they're 90% better. So I'm not saying that it's the thing to do right now, but down the road at some point in the future, it's going to be maybe, if we live long, maybe for our children and grandchildren, the answer to arthritic knees. There are a lot of unknowns every day in arthritis, but it's an exciting field because it does change every day. And with that, I'd like to finish up. I think I've talked about all I can in 35 or 40 minutes. As this size says, I can't think of a blessed thing to preach about this morning. So with that, I would like to close and entertain questions. And thank you very much for your wonderful attention. As I mentioned earlier, I usually learn more from you than y'all learn from me. So let me try to answer any questions you might have.
When are you going to start doing that kind of thing?
The stem cells?
Yeah.
She was asking, when are we going to start doing stem cells? Great question. It's being done in certain centers now. I think until it's an absolutely tried and proven technique, until we have enough follow-up to see if it works for just 6 months or does it work for 6 years and 10 years. So to answer that, my hunch would be, my guess would be probably 5 to 10 years. Not tomorrow and not this year. Yeah. Yes, ma'am.
Yes, sir. What is the difference between psoriatic arthritis and that kind of pain and regular arthritis?
Great question. She asked, what is the difference between psoriatic arthritis and regular arthritis? Great question. Psoriatic arthritis is a type of arthritis. It's related, we see it in certain people who have psoriasis. You're familiar with psoriasis, the skin condition that you get around your knees and elbows. About 15% of people who have this psoriasis can also get psoriasis of the joint, if you will. The psoriasis gets in the joint and it causes arthritic symptoms just like some of these. It's most typically in the hands. It's a type of arthritis for those of you in the room that play golf. There's a pretty famous golfer named Phil Mickelson who was diagnosed with psoriatic arthritis a year ago. And he's taken a medicine called Embrel. Embrel is a medicine that we use for rheumatoid arthritis. But it's also it's similar to Humira, which is another arthritis medicine. But Embrel is a medicine that some folks are using for psoriatic arthritis. Basically, psoriatic arthritis, it causes more inflammation than run-of-the-mill degenerative osteoarthritis. It's a great question, and I probably see a couple of cases of that every year. Yeah, thank you. Yes, ma'am.
Do you see very much rejection of these?
She asked, do we see very much rejection of a knee replacement? Another great question, and a very important question. You know, rejection, per se, usually means infection. If the knee joint gets, or prosthetic joint gets infected, the body no longer can tolerate it, and it tries to reject it. And you start getting pain, swelling, fever, drainage from your joint. The incidence of rejection or infection, thank the Lord, is small, but it's still there. I tell patients that ask about it, it's probably in 500 knee replacements that we do. There'll be a handful, maybe 3, 4, or 5, that have some type of infection. Some of those can be treated simply with antibiotics and maybe a procedure to wash the joint out. There's some, though, that don't get well, and unfortunately the answer is to have to go in, take the joint out, and start all over. It's one of those complications I mentioned earlier that you have to factor into your decision making, just like I did when I had my knee replaced, as to whether your pain is worth the risk of that potential problem. Thank the Lord, it doesn't happen often. We can, we give antibiotics to manage that. We do our surgery in a special room. We do certain things to prevent it. But to answer your question, it can still happen. Yeah. Yes, ma'am.
Dr. Kelly, how long usually does a replacement last, and how do you know when it's time to do it?
Y'all got perfect questions. Thank you. She asked, how long will a typical replacement last, and if it's starting to wear out, how do you know it's starting to wear out? A great question, because when I started doing knee replacements back in the 1970s, early 80s, we would tell our patients, this thing's going to last us about 10 years, and we would have to come back in and start all over. I'm glad to say, because of the improvements in the materials we use, because of the improvements in the way we put them in. For a knee replacement, I can tell you that it's very possible that they'll last 25 to 30 years for a knee replacement and probably for a hip replacement. If you take care of it. That means you got to keep your weight down. You don't need to be going out running marathons or something crazy like that. You've got to do the normal activities that someone our age would do. You don't need to go crazy with it. You need to keep your weight down and take care of your knee. And if you do, we don't know for sure, because some of the materials we're using now have just been available a few years. But I'm telling patients maybe 25 to 30 years. And the second part of your question, how do you know it's starting to give you trouble? Typically pain, you'll start getting pain that you've not noticed previously, or stiffness, and that's usually because your knee will start to swell up. And the muscles get weak, and your knee sometimes can have a chance to start, or will start buckling or giving out on you. And so when you get pain, if it gets stiff, if all of a sudden you start having swelling, symptoms that you not had before, then that's the tip off. You need to get checked and see if that is starting to wear out. Fortunately, with the materials we're doing now, that's further and further down the road than it used to be. Great question. Yes, ma'am.
I had a partial hip replacement a couple of years ago. No problems until recently, and I have got severe pain in my hip. The hip that they did surgery on.
Yep. And that was for a broken
I
hip.
fell. I just
Right.
fell.
Yep. Her question was, she had several years ago,
2 years ago. 2 years ago.
2 years ago, I'm sorry, 2 years ago, partial hip replacement, which means instead of replacing the ball and the socket, sometimes after an injury or a broken hip, you don't replace the socket because that's more surgery. If the socket looks okay, in other words, your socket's not arthritic, you can get by just replacing the ball part, which means less surgery. The problem is, a certain percentage of patients, after a period of time, your artificial ball can start rubbing against your own cartilage. That can start wearing down the cartilage in your hip. That may, I can't tell you for sure, that may be the reason, that's the most common reason to start having problems.
Never had any pain with that hip at all until just the last few days.
Last few days. I'm sorry, if you just started hurting the last few days, that's a good sign, because it probably come from something else, and you can maybe get that better with some medicine or a shot or so. We'll talk about it.
I'll go see you. I'll go see you.
Yes, ma'am.
I think that I need to have my right knee replaced. I'm 35 years old, but I had a really physical job and sort of sped up the deterioration process with it. But I've been told that in my right thigh bone, my femur, I have an avascular necrosis. Would that make me completely ineligible for the knee?
Okay, thank you. Her question was, she is young, 35, and has a bad knee, and she has a condition in her knee called avascular necrosis, which basically means the end of the bone has died. It's lost its blood supply. So her question was, is she still a candidate for a knee replacement? And the answer to that is probably so. Folks who have avascular necrosis, there's no reason you can't have a knee replacement. The only problem is there's a little bit more incidence of complication with your condition than it is a run-of-the-mill arthritic condition. Yes, you can. You're only 35. The longer you can put it off, the better, because, you know, if you're 35 now, when you get my age, you can probably have to have it redone. But you just put up with it as long as you can, and you ask yourself the questions I asked up here. It really affects your quality of life. Maybe it's time to do something.
Most of the time I'm in a wheelchair and I literally can't do.
If you're in a wheelchair and to that point, it's something to consider. Yes, sir.
I have two questions, please.
I'll try to remember both of them.
How can you tell the difference between developing gout and osteoarthritis for the particular symptoms that
Okay.
distinguish it?
Yep. And I can remember that one. Tell me the second
The
one.
second question has to do with the drug called Arthritis. Is that one of the NSAIDs that not recommended for long-term use?
Okay, thank you. Let me repeat those. I'll repeat the second question first, and maybe I'll remember the first one. He was asking, he's taking a medication, a so-called NSAID, a non-steroidal, called Arthritic, which is one that you see advertised a lot and one that we commonly use. It actually is a combination of Voltaren and Nexium, so it helps to protect your stomach. To answer your question, it is definitely one of those we talked about up here. If you take that long term, there is you need to be followed carefully to make sure you're not getting any kidney or liver problems, and you need to be careful taking it that it doesn't upset your stomach. So it is definitely one of the ones that I mentioned up here earlier. Your first question was, how do you diagnose or tell the difference between gouty arthritis and regular arthritis? A couple of ways. Number one, it hurts a lot worse. You have acute flare-ups. Most typically, it's right here in the big toe, right, the base of the big toe. The joint will be swollen, red, inflamed to the point that you can hardly look at it. It hurts so much. Gout can also involve the ankle and sometimes the hands and the wrist. The symptoms, thank the Lord, the acute symptoms are self-limiting. Usually after a period of 1 to 2 weeks, they'll gradually go away, but we usually try to treat it in the meantime. And of course, you need to diagnose gout by doing a blood test, and that's when you find if the chemical I mentioned earlier, uric acid, is elevated. But the symptoms from a gouty attack are much more severe than regular arthritis, but usually will go away after a week or 2 or 3. But it's a miserable week or 2 or 3. Hope that answers. Yeah, yes, ma'am.
Is there a way to avoid gout?
She asked, is there a way to avoid gout? One way is to be a female. You're in good shape, because females, as I mentioned earlier, are probably 10 times less prone to have gout. But for the rest of us, you're gonna get it. If you're gonna get it, you're gonna get it. There's no way to avoid or prevent gout. It's something that is hereditary. It's in our genes. Sometimes it'll start in teenagers, sometimes in middle age, sometimes in old folks. But it usually does not start in ladies until, say, after age 50 or 55. So you got plenty of good years left.
Looking in your diet could
She asked, is there anything in the diet that helps prevent gout? Great question. Probably not to help prevent it, but if you've got gout and you want to prevent attacks of gout, you'd be smart to avoid a lot of red meat, avoid a lot of wine, a lot of beer. They say that's why Ben Franklin had such a time with it. I'm sorry to ruin your day. Yes, sir.
You didn't mention the lower back pain.
Right. He asked, I didn't mention lower back pain, and you're exactly right. You know, I was thinking when I put my talk together, how do you cover arthritis in 35 or 40 minutes? And you're right, I did not mention that. Because lower back pain is one of the most common types of arthritis we see. It's caused because the cushions in the back, the cushions or the disc between the bones, start to wear down as we get older. The discs are normally like a sponge. They've got moisture in them. As we've had a few birthdays, they start to lose moisture. They become like a sponge that's left out on the sink for about 3 days. When that happens, arthritis sets up. Arthritis in the back is a particular problem because as you develop bone spurs in the back, it puts pressure on the nerves, which makes the pain worse. It also makes the pain go down the nerves into the legs. The treatment for that at first is the things we talked about, maybe trying some of the medications we mentioned, making sure your mattress is a comfortable one, and making sure the box springs are not worn out. A lot of times people replace the mattress, but the box springs are 25 years old. So make sure that you've got good bedding, take medication for it. The other thing that can make a huge difference for arthritis of the back is exercise. There are certain exercise programs that can really make a huge difference for back pain. And as you might imagine, losing any weight, you don't have that problem, but some of us do, and losing weight gets pressure off the back. Everything else fails, we can give cortisone shots or what's called an epidural injection, which is like a nerve block that we do.
You got a specific doctor down there?
Yes, it's Dr. Richardson, my older partner, does most of that part.
I read a letter that somebody wrote to him in the paper that praised him about.
Oh, he loved that. He saw the letter in the paper that he got one of the patients to write. I kid him about Yes, yes. You got time for one more?
Yes, sir. I got one over there too. We'll get
Okay, I'll start over here.
Well, that was
Okay.
a perfect lead up to the question that I had. You mentioned that cortisone might wear out the joint or speed up the process of the arthritic process. What are your thoughts on the spinal block and what it shows?
Okay. She asked, you know, as she noted, I mentioned during my talk that cortisone can accelerate the arthritic process in a joint. And so she was asking, what about an epidural or a nerve block? What effect will cortisone have on that? Fortunately, not much, to answer your question, because the medicine is not given directly into a big joint. It's given around the nerve to help control the inflammation and swelling. Typically, we don't do with a series of 3 of those at one time. If we repeat it, we usually wait 6 months or more, just because we don't want to have any other effects from cortisone. But as far as the cortisone wearing out the back or the disc, unfortunately with a nerve block, that's not a concern. Great question, but usually we don't have to worry so much about that. Yes.
Dr. Geller, would you speak to the application of heat and cold to the joints?
I sure will. Thank you. The question was, what about the use of heat and cold on the joint? That's a great question, one I get every day, and I should have mentioned, in fact, I had a slide about that, and I took it out because I didn't know if I had enough time. Typically, for an inflamed arthritic joint, whether it's osteoarthritis or rheumatoid arthritis, and most of you will probably disagree with me, but ice works better. Ice is better for inflammation than heat. It helps to control the swelling in the joint, and most of the time for an acutely inflamed joint, the ice is better. That being said, there's sometimes, particularly with a muscle ache, if you can differentiate the two, perhaps particularly in the back sometimes, moist heat, not a dry heating pad, but a hydroculated pad or heating pad with a towel wrapped around it. Moist heat can help with a muscle pain, but I like to use ice for the acute joint pain. That's a great question, and you know, I tell patients that, and they come back and say, well, I tried that, it didn't work, but heat worked better. Try heat then. But most medical authorities will tell you that the ice is the best thing to use for an acutely inflamed joint. It's a great question. I should have kept that slide in. Yes, ma'am.
Should you be on the diclofenac for a long period of time?
Okay. She asked, should you be on diclofenac for a long period of time? Diclofenac is the same medicine the gentleman in the back of the room asked about. It's a medicine that is in Voltaren and Arthritic. So it's a non-steroidal anti-inflammatory, which means it's got the very complications I mentioned up here. Gastric problems, kidney problems, liver problems, even heart problems. So if you're on that for a period of 6 months or so, I would strongly recommend getting blood tests to make sure your kidneys and liver are okay.
How about Nexium?
I'm going to get to that in 1 second. And you know, if the blood tests check out okay, you know, keep going with it if it helps. But be aware of those potential problems.
I'm calling it
because that's definitely one of those.
And the diclofenac doesn't work, and she doesn't know what to take for pain.
Okay. Well, she said if the diclofenac doesn't work, she doesn't know what else to take. But as long as the diclofenac works, and as long as the blood tests are okay,
Yeah.
you know, keep taking it as long as the liver and kidney are okay. And the other question was about, what about Nexium? Nexium is a medicine that we use for gastric reflux. I don't know a whole lot about it. It's a little bit out of my bailiwick. But I mentioned it earlier because it's the medicine that's also in Arthritic. Arthritic is a combination of diclofenac and Nexium. They put Nexium in to try to help prevent gastric reflux. So I don't know what the long-term consequences of Nexium are. Probably not nearly like they are with some of these other medicines that we've mentioned. Yes, ma'am.
Thank you, Dr. Kelly. I know we could probably go all day.
I'll stay up here if they need.
Okay. Dr. Kelly will hang around for just a little bit. I know some of you had to go. And if you would, allow me,